మంచిగా అంటున్నారా? మనకి ఎవరన్నా ఫిజిషియన్ పల్మనాలజిస్ట్ ఎవరైనా వస్తే బెటర్ అని చూస్తున్నాను. ఎందుకంటే మన వాళ్ళు ఎట్లా ఉన్నారు కదా, మనందరం అనసిస్ట్లే కదా.
గుడ్ మార్నింగ్ సార్, సతీష్ గారు. సతీష్ గారు
ఏంటి భయ నిఖిల్? Station.
Good morning, Satish garu.
Morning, sir. So, morning.
Morning, sir.
భక్తులందరూ నిద్రావస్థలో ఉన్నట్టున్నారు.
Sir, good morning, Chetan.
Good morning, sir.
Hello, sir. Good morning.
Good morning, David.
Sir, good morning, sir. Good morning, Dr. Chetan.
Yeah, good morning, sir.
అన్నా మార్నింగ్
Good morning, Anna.
స్టార్ట్ చేయాలా? ఎప్పుడు చేస్తావు చూడు.
చేద్దాం.
చేతన్ గారు, మీ ఒకసారి ఆడియో చెక్ చేసుకోండి, కొద్దిగా క్రాక్లింగ్ లాగా వస్తుంది.
Can you hear me now?
Yeah.
Yeah.
Okay.
Just you can increase the volume a little bit.
Yeah, it is increased, sir.
Okay. Right.
Sir, you want laptop volume or human volume? Huh?
1 second, sir.
The audible volume is enough, sir, whatever it may be. అంతే కదా.
అవును.
అవును సార్, గుడ్ మార్నింగ్.
గుడ్ మార్నింగ్ సార్.
ఎప్పుడు స్టార్ట్ చేద్దాం అంటే అప్పుడు స్టార్ట్.
ఆల్రెడీ 10 మంది వచ్చారు కదా సార్. మన డేవిడ్ సార్ చెప్పాలి అంతే, మనదేంది. థర్స్డే క్లాస్ ఇస్ ఓన్డ్ బై డాక్టర్ డేవిడ్ జాన్ జడ్జారి. డేవిడ్ లేడా? ఉన్నాడా?
ఉన్నాడు సార్, కానీ మ్యూట్ లో ఉన్నట్టున్నాడు.
డేవిడ్, హలో.
మార్నింగ్ వరలక్ష్మి మేడం అండ్ శ్రీకాంత్.
సార్ గుడ్ మార్నింగ్ సార్.
Sir, good morning. Shall we start?
మీరు ఎక్కడో మ్యూట్ పెట్టి వెళ్ళిపోయారు. మీకు ఇందా నుంచి మిమ్మల్ని పిలుస్తున్నాం సార్.
ఉన్నాను, ఇక్కడే ఉన్నాను సార్.
మరి పలకట్లేదు ఇందా నుంచి.
నేను రెస్పాండ్ అవుతున్నా, తర్వాత చూసాను మీట్ లో ఉందని. అంటే మీరు వస్తే స్టార్ట్ చేసేద్దామని.
లేదు సార్, స్టార్ట్ చేయండి సార్.
Good morning, all of you. Today, Dr. Chetan Shirodkar is talking on ultrasonographic optic nerve sheath diameter to assess the ICP. So, new topic and useful in ICU. Now, I request Dr. Chetan to start the presentation.
Yeah, just a minute now.
అందరికి ఎక్కువ ఇంట్రడ్యూస్
Just a
చేయండి
minute.
సార్ సతీష్ గారు.
Just a
Yeah.
minute. That's what I'm planning. Chetan is with the Morton team for the last 8 years, working in Secunderabad Apollo. He is a student of critical care from Manimala Madam, and he and Manimala Madam actually done a study on ONSD vis-a-vis comparison with in welding ICP monitoring. So he's the primary author for that paper, which is being published in ICCM journal. So it is over to Chetan.
Good morning, everybody. Thank you very much for the kind introduction. Today's topic is on ultrasonographic optic nerve sheath diameter to assess a intracranial pressure. Being ultrasound is a point of care in a modern ICU, so the timely detection and treatment of the ICP is very important. The normal intracranial pressure is around 7 to 15 millimeter of mercury in a resting state. Any neurological or a non-neurological trauma will lead to an increase in intracranial pressure, which in turn leads to secondary brain injury, which starts within minutes to hours, leading to the destruction of the pathophysiological cascade, leading to a decreased cerebral perfusion, oxygen delivery, and nutrients. At the same time, there will be a destruction in the waste material and the toxins, which exacerbate the further ischemia. If the ICP is not maintained less than 20, or it goes more than 20 millimeter mercury, it obviously will have a poor outcome. What are the different causes of intracranial pressure, raised intracranial? One is the neurological, which are aneurysm rupture, encephalitis, head injury, intraventricular hemorrhage, status epilepticus, subdural hematoma, cerebral edema, epidural edema, hydrocephalus, meningitis, stroke or intracerebral hemorrhage, or the tumor. Other non-neurological causes, it could be a hepatic encephalopathy, acute mountain sickness. So to understand raised intracranial, first you should know what is normal ICP. The brain is covered by the rigid structure called a skull, which contains a venous, arterial volume, brain, and the CSF. Being brain is a form structure which contains a lot of water, which maintains equilibrium within the brain, and which is maintained by the normal cerebral blood flow and absorption and secretion of the CSF. Normally, any increase in ICP will be compensated by the displacement of the CSF or a venous blood out of the CSF compartment. So the ICP will be maintained. When the mass size of the brain is increases, there will be an increase in intracranial pressure. So what the Monroe-Colley doctrine said, it will try to maintain the normal ICP by displacing the one of the structure. So as the compliance decrease, there will be a sudden rise in the intracranial pressure, which will directly displace the CSF around the optic nerve sheath diameter. The optic nerve sheath diameter being in close contact with the central nervous system, which has got a direct communication with a subarachnoid hemorrhage. So there will be immediately it will be transmitted to this optic nerve sheath diameter. Whereas the papilledema, it will take hours, minutes, longer time to displace on the ophthalmos clinically. So this is the volume pressure curve where the compensation starts point of decomposition. So there will be a sudden rise in intracranial pressure, which will be an alarming situation. So what is the monitoring of intracranial? The gold standard of invasive intracranial pressure is the ICP is the gold standard. So it will be either by placing an intracranial catheter into the ventricular or CSF. So the various methodologies available in epidural, intraventricular catheter, strain gauge or tip transducer bolts. So this has got disadvantages because of infection, hemorrhage, malfunction, and non-feasibility of neurosurgical expertise at the bedside. Plus, there is a contraindication, which will be contraindicated if there is a coagulopathy, thrombocytopenia, and a high cost. Other non-invasive modality is intracranial and extra. Intracranial are ultrasonography, the time of flight technique, transcranial Doppler ultrasonography, acoustic measures, MRI, EEG. Extracranial tympanic membrane displacement, autoacoustic emission, optic nerve sheath diameter, ophthalmodynamometry, optical coherence, tomography of it, and jugular vein, that where they compress the jugular vein to much. The history, as we know, it was Sohan Singh Hare was the first one to diagnose that there is a constant communication between the subarachnoid space, optic nerve sheath, and the intracranial cavity. If you can see the anatomy, the optic nerve, the orbital portion of the optic nerve is in direct communication with the intracranial cavity through the subarachnoid space. Whenever there is a increase in intracranial pressure, the CSF will be displaced around the optic nerve sheath diameter. So as you can use this as a relationship, as a surrogate to diagnose a marker of intracranial pressure. So Helmach and Hansen in 1996 used the B ultrasound mode to measure the optic sheath. Earlier they used to use a scan, but which was not possible to use a measure the optic nerve sheath, because you need a transverse section of the optic nerve sheath diameter, which you can measure a 3 millimeter behind the globe, because the 3 millimeter behind the globe is the maximum dilatation of the optic nerve sheath diameter, which is proven in the cadaver patients. So what is the evidence? The Duberg et al. As a meta-analysis of 6 studies, which contains up to 36 patients, which has got a pool sensitivity of 90% and the specificity of 85%. So, and whenever there is a patient with increased ICP, or will have a 51 times more likely to have a positive ONSD. So how do you perform the optic nerve sheath diameter? So normally we ask the patient to close the eyelid, apply a good amount of a jelly. This requires a high frequency transducer with linear array high frequency transducer. So you will place the ultrasound probe transversely on the closed eyelid and ask the patient not to move. As you move the transducer, you will try to see the structure which will appear in the screen as first it will be a cornea, followed by the iris and the lens, and the anterior chamber and the posterior chamber. When you align in such a way that you get all these structures in a one transverse section, where the optic nerve will be appear as a black strip, which is hypoechoic nature, whereas the hyperechoic structure will be the optic nerve sheath. So any increase in the ICP, which will be transmitted to this optic nerve sheath diameter, which is thinnest portion of the nerve. So if you can see this is the optic nerve, where you globe ultrasound, where you see the lens, and then is the optic nerve sheath, which is a black strip. As then you have to freeze the image in the ultrasound, use a caliber, and measure optic nerve sheath 3 millimeter from the globe. See, this is what we do it. So 3 millimeter behind the globe, you measure the optic nerve sheath, and you have a perpendicular diagram as a second line, which will be the measured, which will be given as a optic nerve sheath diameter. So what is the normal optic nerve sheath? In most of the adult male, the optic nerve sheath diameter is less than 5 millimeter of normal, where pediatric between 1 which for less than 4.5, infants 4 millimeter. There's only one study which has proven that, which is a meta-analysis, that it found to have an optic sheath of more than 5 millimeter mercury. The ICP is more than 20 millimeter of mercury. This is what has been proven. But what is the mean inter-observer variation is around 0.1 millimeter in the different population, which is proven in the normal adults, published in the European Journal of Ultrasound. So this is a summary of a published study estimating optic sheath diameter in a healthy volunteers. So each they have seen in Asian population and the Western population. In the Asian population, the cutoff point of a normal optic sheath diameter is varying from 3 to 4.8, where our study is also taken into account, where the optic nerve sheath in a female was around 4.8 and a female was around 4.6. Similarly, there in Chinese population, it was around 3.46 to around 3.2. So whereas in Western population, the normal is itself is more of the study is more than 5 millimeter of mercury. So there is no clear-cut demarcation what is a normal optic nerve sheath diameter. So it varies from ethnics from different countries. So before when we came up with the study of optic nerve sheath diameter, we didn't have a normal study or optic nerve sheath cutoff point in our Indian scenario. So we took a control of around 40 patients, 41 patients, and we came to a conclusion, and based on that, we went ahead with our study. So what are the benefits of this optic nerve sheath? It's a non-invasive, portable, can be repeatable very frequently, no radiation, can be performed rapidly, it can be used in rural places, avoidance of patient transport to imaging, and can be used in osteal medicine environments. So how many scans can a person, newcomer can do it? The experienced sonographer can perform with 10 scans with 3 abnormal, whereas if newcomer, a minimum of 25 scans can be used. So is it safe? Yeah, it is very safe because of it is minimum, the scanning time is less than 5 minutes, no Doppler. It has got as low as reasonably achievable. And this is very important, the mechanical injury or the thermal index injury. We try to maintain less than 1. Whenever we do ultrasound, the sound wave will be transmitted through from the probe to the tissue, and it will be given as a reflection. During this phase, there will be the absorption of the energy, which will cause an increase in temperature of the tissue. So maximum allowable time to temperature is around 1 degree centigrade. And mechanical injury, these are all non-thermal index injury, non-thermal injury, where we can have there is a risk of a cavitation and expansion. This is very common when there is a optic globe injury or any patient who has got a glaucoma. So the chances of injuries will aggravate if the non-thermal injuries are very high. So papillary edema, as we know, it is a late sign of intracranial pressure. It takes hours to reflect on the fundus. So, and it has got a less sensitivity and less specificity. And why it is very difficult, it has got an anatomical difference. It requires the eyes to be dilated, and there is asymmetry in that. So what are the causes of optic nerve sheath diameter? Without elevated ICP, it can have optic neuritis, arachnoid cyst of the optic nerve trauma, anterior orbital or cavernous mass sign. With elevated ICP, tumor or a space occupying lesion, idiopathic intracranial hypertension, decreased CSF resorption, visually venous sign thrombosis, subarachnoid hemorrhage, increased CSF production tumor, obstruction of the ventricular system, cerebral edema, encephalitis, and craniosynostosis. So these are the 3 case scenario where the optic nerve sheath has been used, and it has helped to come to further managing the cases. A 70-year-old male with multiple comorbid with sudden cardiac death, whose CPR was revived and admitted in the ICU, which was sedated and ventilated. Patient was not able to open the eyes, and the pupils were, and they did an optic nerve sheath diameter. It was found to be 6.45, and subsequently they did a CT scan after stabilization. It showed a heavy malformation with cerebral edema, with the EEG showing a presence of status epilepticus. So the patient was immediately transferred to a neurological ICU. where he died later. So this optic nerve sheath diameter can help to find out what is the real problem in the intracranial cavity. So one more case report with polytrauma with 52 years had a multiple structures with severe ARDS with AKI requiring a higher vasoactive medicine. He was having a dilated bilateral pupils with absent light reflex, deeply sedated, no injury to the intracranial lever. So CT was planned but could not be done. So they did optic nerve sheath diameter, which is 3 millimeter. So they ruled out any intracranial injury. So these are the some of the studies which have been conducted for between 1997 to 2015, where they are trying to establish the proper cutoff of optic nerve sheath diameter as a marker of a raised ICP. Some are the study. One is the optic nerve sheath detection of a raised done by the Rajeji et al., where they used 65 patients were measured, 536 patients, 65 patients, where they found that there was a increased ICP where the optic nerve sheath diameter was more than 408 centimeter. And ICP was measured by using an invasive way of measurement, where they found a received operator curve is for more than 20 millimeter mercury was 96% with sensitivity with specificity of 94%. Similar, another study, there was a prospective blinded observational study in an adult patient who came to an emergency department. It's possible to have a raised intracranial pressure. The measured the optic nerve sheath diameter, and they compared this optic nerve sheath diameter along with the CT findings, which has got a raised intracranial pressure in the form of effacement of a sulci, intracranial mass shift, or a cerebral edema. And where they found is that of 8 patients of the optic nerve of 5 millimeter of a millimeter had a raised intracranial pressure in the form of the CT. So the sensitivity and specificity was good. The specificity was 100%, whereas the sensitivity and specificity was 63%. So with this, they have come to a conclusion: the optic nerve sheath diameter as a potential sensitive marker, which can be used as a screening of a intracranial pressure. Another study, which is a pilot study, where they are done in pregnant females, where they measured optic nerve sheath diameter in a pre-eclamptic patient and a healthy pregnant female. And there was a difference of in a pre-eclamptic patient, the optic nerve sheath of 5.4 millimeter versus 4.5 millimeter in the healthy pregnant woman. And at the time of delivery, 5 of these patients had a optic nerve sheath diameter around 5.8 millimeter of mercury, which is more than the normal healthy pregnant woman. And subsequently, this optic nerve sheath diameter has decreased after the delivery of the baby. So the postpartum, the optic nerve sheath came down by the 3rd day to back to the normal level. So this study also tried to establish the relationship of optic nerve sheath diameter with the intracranial pressure. This is one more study which Kimberly and Nato tried to correlate optic sheath diameter with the direct measurement of intracranial pressure, where they found that and they used as Spearman rank correlation coefficient of the ICP, where they found a positive correlation with the ROC curve is around specificity of 93% and the sensitivity of 88%. So these also try to establish a correlation of optic nerve sheath diameter with the more invasive ICP by using a ventriculostomy. This study also another detection of a raised pressure by ultrasound optic nerve sheath diameter in African children, where there are 14 children with neurological disease and clinical signs were diagnosed to have a raised ICP, and which the optic nerve sheath diameter was 5.4 millimeter. and radiologically on a CT showed the presence of a raised ICP in all those children. So, but optic nerve sheath diameter in this control shown a specificity of around 100% and 86% respectively. This study also tried to establish raised ICP with a broad range of setting in children. This is our study where we try to prognosticate the optic nerve sheath diameter, the evaluation. What we did, we didn't take any trauma patient, we took a purely medical cases which have got a possibility of a raised ICP, who came with the hospital with the vomiting, headache, altered sensoria. In this patient, we examined the optic nerve sheath diameter and we compared with the ICP, which has been diagnosed by using a CT scan or an MRI. So the finding what we took on a CT scan or MRI as a midline shift edema assessment, and in a MRI due to optic nerve sheath more than 5 millimeter of mercury, 5 millimeter. We suggested as a raised ICP and MRI, we compared that with the patient with the, we had done the ONSD. So what we found that of those 60 patients, there were 17 females, which optic nerve sheath diameter was 5.1 with a standard deviation of 0.6, and the p-value is less than 0.5, whereas for males it was 5.0. And this was compared with the radiological finding. Of these 35 patients had a clear-cut sign of a raised ICP in a radiological as well as the optic nerve sheath diameter. And the sensitivity and specificity was encouraging in these two group of patients with 84% and 75% with 100% specificity. And there were few cases, around 10 patients, which radiologically did not show any raise in intracranial pressure, but ONSD was marginally elevated. So with this, we came to a conclusion that optic nerve sheath diameter can be used as an early test for a diagnosing of a raised ICP rather than the invasive. So one more same study we interpolated with the MRI and CT, where we measured the optic nerve sheath diameter through the radiological scanning, and whatever data we had, we compared by using a blunt Altman analysis. So in this both the comparison, we found that p-value was less than 0.001. So this also study we tried to, but still cutoff point is not available till now for a precise measurement of the optic nerve sheath diameter, so that we can say that particular point of optic nerve sheath diameter is the marker of an increase. As another study which they did a transorbital ultrasonographic measurement of optic nerve sheath diameter, where they did measured in a brain death and a comatose patient, which they found that both the group of the study are found to have raised optic nerve sheath diameter, but there is no clear-cut evidence of both the group to have whether the ICP is raised or not. So this is the different group of studies which was performed all over the world, and they have given the summary of the study which is conducted between 1996 to 2015. There are some 42 studies, and if you see in all the studies, each study has got a different cutoff point. Some study has got a 5, some study has got a 5.7, some study has got a less than 5. So there is no clear-cut demarcation. So still a lot of work has to be done to come to a conclusion what is the exact number of a figure in optic nerve sheath. In this also they have tried to address our study also in a medical patient. So still non-invasive intracranial pressure optic nerve sheath diameter can be used as if there is a timely detection and So conclusion is timely detection and treatment of raised intracranial pressure are essential for preventing secondary brain damage and related morbidity and mortality. The gold standard for accurate ICP is always invasive, but because of expertise required at the bedside and coagulopathy and high cost, it is not possible all the time. Optic nerve has been shown to correlate with the increased ICP, which appears to be promising non-invasive and radiation-free bedside to assess elevated IP. The diagnostic accuracy of optic nerve sheath ultrasonography cutoff value in predicting raised elevated ICP compared to an invasive ICP measurement at different threshold needs further investigation. Thank you.
So lot of time to discuss, Satish.
Yes, sir. Yes.
Thank you.
Chetan, nice presentation. Did you mention that what are the false false positives for the ONSD? Optic nerve sheath diameters?
Chetan.
Yeah. It depends on how do you measure the optic nerve sheath diameter. If there is a probe is not kept properly in a transfer position, if the normally you will see the, I'll show you the scan. Yeah. So if you see this image, whenever you're trying to measure optic nerve, you have to get all the structures in a transverse position, transverse axis properly, which includes a cornea, iris, anterior chamber, lens, and that. If there is if this image is not achieved properly, then you will have false positive results, because the optic nerve sheath diameter, the section will change, and that is the time where you found to have a different value in this. So this inter-observer variability, whatever is there, it try to address, but this so far there is only one study which is available, which is showed as only as a 0.1 mm as a variation.
No, that is the inter-observer of this thing. The potential false positives in this one optic nerve sheath diameter is one is optic neuritis, second one is optic nerve glioma, third one is optic nerve meningioma, and any inflammatory infiltration around that area, Graves orbitopathy, leukemic infiltration, orbital congestion with sheath swelling.
Yeah, I forgot to mention that.
Yeah.
You can have a positive, false positive.
Yeah, I will share that one to our group, no problem. Nice presentation. But thing is, why it is not popular, so much popular nowadays? In actually 2008 to 2014 area, it was one of the evaluating this thing, but later actually people are not much interested. What could be the reason?
Measuring ICP, sir, directly.
Good morning, sir.
Sir, good morning. They are measuring directly the ICP in all majority of neuro centers. So when false positives are more, and it is all subjective dependence.
Then this one, everybody is now doing. Most of them are practicing it, sir, in the ICU.
Yeah, it is just evolving way of this. This needs to be done regularly. The second thing is availability of ultrasound in the ER all the time. Actually, they should use this.
Machine is available, sir, with everyone now in the ICUs.
But nobody is concentrating on that aspects.
Yes.
No, everybody is measuring it. Actually, most of the patients with encephalopathy or any other reason also, we are measuring this optic nerve diameter in the patients, and we see the trends of that. If it is increasing or decreasing. Only issue is what decision has to be taken, we don't know. Because one will tell us that whether ICP is high or not. But what is the point where we need to the number, like This is only a
Number
diameter.
is
What is
still,
the
there is no
pressure?
clear-cut number till now.
Yeah, what is the pressure? Yeah, one is cutoff numbers we don't have.
Yeah.
Second thing is we can see the trends. Third thing is what is the raised ICP number in the brain, we don't know.
Exactly.
How much mmHg? That is again a problem with that.
Yeah.
But ultimately, if there is a trend towards increase, then we should be more cautious and we need to treat appropriately.
Here also you are trying to analyze one study with optic nerve diameter invasive ICP, where post-operatively we try to analyze how the trend of optic nerve sheath is coming. We are trying to maintain the ICP less than 20. So somehow that statistically it has not given a positive result in that. So because of that difficulty, I'm not able to come to a conclusion what to do on that.
As Srinivas sir told, no, it is like trending is one thing is important. Second thing is, it's like a screening test. If you feel that optic nerve sheath diameter is significantly more, maybe it is ranging from different studies telling from 4.5 to even 6.3 or 6.4. So any value that is touching to the higher side, like 5 plus, maybe we can.
అయింది కదా నైట్ ప్రాక్టికల్ గా బ్లీడ్ అయింది అక్క ఎలాగంటే సర్జికల్ సైట్ అయ్యింది ఓరల్ గా కూడా అయిపోయింది చాలా అంటే చాలా అయిపోయింది ప్యాడ్ అన్ని ఒక 3 అలా తెరిచిపోయాయి సర్జికల్ సైట్ ఐ ఓపెనింగ్ ఏం లేదు కానీ సర్జికల్ సైట్ నైట్ ప్రాక్టికల్ గా బ్లీడ్ అయ్యింది చాలా ఎక్కువగా ఓరల్
ఇప్పుడు చెప్పండి సార్
అందరినీ హోస్ట్ డేవిడ్ ఉన్నాడు కదా.
So what we just like maybe the take home point, maybe if it is touching on the higher side, is something going more than 4.5, more than 5 or 6 or something like that, maybe it should raise a flag that there is a possibility ICP is going beyond 20, and we have to continue with the serial trends. Yesterday it was only 3.5, today it might be showing 5 plus. So there is a possibility of trending towards rising ICP is going to establish here. Maybe at that point of time, we need to go for the next level of investigation, which is more invasive, and this is non-invasive thing. So it can be taken as a screening tool.
Is there any comparative study along with TCD? Means TCD and optic nerve?
There is one study available along with the transcranial Doppler, but it has not showed any positive result in that.
Because TCD is we'll use it for raised ICP at the same time comparison with optic nerve diameter.
One study has come up, sir, but it has not showed any positive result in that.
Okay. When you did this study, sir, you mentioned your name and Dr. Manimal Rao.
This was way back in 2014 when I was doing my fellowship with madam.
Okay.
Yeah.
So he said for new person, that is 25 times you will give one positive.
Minimum scans required around 25.
To say one positive. One correct.
Yeah. No. This is for a newcomer who wants to learn how to do the measurement of the minimum 24 scans are required.
Okay.
So they'll get used to that.
Right, sir.
Yeah.
But this, so what are the invasive tests we are doing, sir, now? One is EVD. Is there any way?
Nowadays, they are using as a EVD, which is connected to the transducer. The placement of the camino catheter into the ventricle.
Any other thing, Sati sir? And PPTO2 అట్లాంటిది ఏమైనా చేస్తున్నారా అపోలోలో?
No, sir. As of now, chairless, sir.
SJVO2.
Only theoretical.
Some people are doing SJVO2, no? In neuro centers.
SJVO2, we also have done, sir, SJVO2, especially for encephalopathy patients, and also for SJVO2 is little crude indicator, sir.
Chetan, while measuring this diameter, is there an importance of checking the papilla edema?
Sir, papilla edema will take a longer time to show it clinically.
Okay.
Yeah, so best will be the optic nerve sheath diameter instead of going for a papilla edema.
So this is one question raised in our presentation in the Eurasian conference in this poster. They're clearly asking us, and the critics telling that why can't you go with a papillary edema? The similar question was there. But normally papillary edema to establish, it will take some time. Once the initial thing is raised ICP translocated into raising, showing some papillary edema will take some time. We miss the initial golden hour. So we need to have a continuous ICP monitoring, invasive, which is cumbersome. So we need to have a serial optic nerve sheath examination as described in the talk. If it is showing any uptrend, maybe it is for early picking up the issue rather than waiting for the papillary edema to develop and then identify that there is a raised ICP.
That means by using the ultrasound, can we diagnose that means papillary edema?
No, I think papillary edema, it is through the fundoscopy, I think.
No. Actually, yeah, they have given this one algorithm. Just I'm sharing.
Yeah.
So if there is elevation of the optic disc, then actually what you are correct to establish papillary edema, it takes some time. But earliest changes is that some elevation changes in papillary disc, the optic disc. So based on that, actually they framed the one algorithm. Just I shared in our group. Just to want to know only. Chetan, any idea?
No, sir.
Sir, earliest is this one. Why? Because as soon as the ICP is raised, that is transmitted to the optic nerve immediately. So there we are measuring it. So earliest is this. After that only the remaining other changes happens.
So and
just I'm sharing that article also.
Okay.
Which one is early patient symptoms or optic nerve diameter? Like
Optic nerve diameter, sir.
ICP is raising, the patient become irritable or altered sensorium.
Altered sensorium, there will be.
Which one is the earliest? Is it altered sensorium or the optic nerve diameter elevation?
Sir, first is optic nerve diameter, sir, for a raised ICP. Altered sensorium can be of many reasons. Patient can have a
no. When compared to ICP, related to ICP.
Relative to ICP, sir, symptoms will come later, sir. With the more. First is this optic nerve sheath diameter.
Yeah, Dr. Surendra, can you highlight your thoughts?
Yes, sir. Sir, I think when there is a raised ICP, the first will be the. Hello, sir.
Yeah,
hello?
Yes,
sir. When there is a rise, any further change in the brain, that will definitely reflect in the nerve first and follow with the papillary edema. That's why we will take as a ONS is the earliest marker to detect the ICP. But the best thing, if rising, first will be the Lingard ratio or TCD that detects earliest than this. And regarding the symptoms, it depends upon the pathology what you are dealing with. What pathology is causing your rise in ICP, which has to be addressed first. If the patient is having altered sensorium, ONSD, I think it depends the pathology, sir. Or traumatic brain injury, or is the SAH.
Traumatic brain injury. Which one is the first?
In traumatic brain injury, sir.
Yes.
Definitely symptoms and these may correlate. There in sudden and rise CP, first will be the symptoms only, I think so, sir. And after that, it increase in the edema. This causes leak. CSF cause and pressure changes causing the increase in the diameter, sir. Maybe I feel it is both. You have to measure it simultaneously.
Symptom comes when there is an ICP. So yes, you are measuring the optic nerve sheath diameter
Yes, sir.
So before the symptoms, it will come. Only thing is, we will not see all the patients optic nerve sheath diameter and the trauma patient until we develop the symptoms.
Yes,
Okay,
sir.
that is the
Yes, sir.
flip side. So if you, without symptoms, if you start checking all the patients optic nerve diameter, you can identify it. After
Yes, sir.
developing the symptoms, and if you know that there is an ICP raise, that is only for training the students. See, now ICP is raised. See the optic nerve sheath diameter, not identifying early.
Yes, sir.
So can
Of course.
I speak, sir?
Yes, Sama.
Sir, basically, see, when there is an obvious clinical
Hello.
there is a clinical situation where you can identify raised ICP. Say, for example, patient is reasonably okay. There is a fall in GCS, or there is the Cushing stride, there is bradycardia, there is anisocoria. You don't need anything, sir. This actually, I think, optic nerve sheath diameter is a situation where, suppose patient, you have sedated a patient of TBI or a stroke or something, and then if you do this, you can't really assess the GCS. You cannot really see a subtle drop in GCS or any other neurological findings. I think this is a game changer there. So if you see do a serial ONST, then you will, if you find there is a raise, because if there is an obvious symptom or sign of raised ICP, you would obviously go for an imaging. There is no two ways about it. But only thing is, if you don't have, you can't assess it clinically. That is when this will have a role. So if you patient is sedated overnight, in the morning, if you see and you find that there is an increase, and you look at it at baseline, and then you see an increase, then you might want to take a decision based on that. I don't think once something like drop in GCS or significant change in apparent neurological situation happens, there is no point in doing an ONS.
ఒకసారి జీసస్ పడిపోయిందంటే సిటీ స్కాన్ చేయడం బెటర్ కదా, ఓఎన్ఎస్డి ఉపయోగం లేదు కదా.
ఎగ్జాక్ట్లీ సార్, అక్కడ దీని రోలే ఉండదు. It is generally in lectures and all, that's what they say. It is useful when patients are sedated. You can't really see subtle changes. Appude, if you have a serial, like sir was saying, not one single number, but you have a serial trend. Say once a shift or once or twice in a day, if you see it, and then you see a change, then it may reflect, or then you might take a decision rather than going for multiple images.
Madam, regarding this one paper, no, they clearly compared with GCS versus ICP monitoring. They clearly told that GCS monitoring is far better. No need of going with an ICP monitoring for all patients with a traumatic brain injury. That is one paper. So the thing is, primary importance is given to the clinical assessment. Whatever you said is GCS, drop in the pupillary asymmetry or a drop in the GCS, new development of focal neurological deficit. All these things are primary thing.
Yes.
Even not happening, maybe when we consider to monitor ICP, then the point of ONSD comes there.
Exactly, sir.
Yes.
Exactly. No, it's not a precursor to that. And if anta clinical deterioration unte, we don't need appudu కూర్చుని ONS kuda periginda leda ani. I don't think that makes any sense at all.
Yes.
So it is all prior to that.
Yeah.
Yes,
First
yes, madam. Yes, madam. Agree. So same thing, as I was also mentioning, that it is a prior to that, and it's a patient who is having an hepatic encephalopathy also. We usually monitor in these patients where your ICP is high or not, because they don't have any, but they don't have any lesions, but it is a possibility there can be a high raised ICP. Even ammonia may not correlate well with the raised ICP, but this is one of the things where you can check it.
Yes, sir, definitely.
Yes, sir. Anything to discuss?
Sir, Chetan sir, you do it in one eye and take a call, or is it like you have to do both eyes, sir?
It is done in both eyes. And try to take more reading, minimum 5, so that you get whatever variations you can nullify in that.
Okay. So you
What is
take
the
a
meaning of
mean, sir, or
minimum
you
5
take
and
the
the
highest, sir, of the measures?
Average.
Chetan, what is the meaning of 5 minimum?
What, sir?
You're telling 5, you take at least 5, no? What is the minimum 5 means? 5 times you have to do?
No. The number of readings. Minimum of 5 times you measure it and take the mean of that.
Okay. Thank you, sir.
Yeah.
Yeah, Dr. Chetan, you are I think you are the best person. You did a paper and
Excellent.
you have more experience in the group. So, are you doing in present days also regularly in all?
Yes. Yeah,
you're
she
doing?
does.
Okay. So, how it is correlating with CT scan and symptoms?
We do see the patient who are coming, and CT scan, most of the patients will have a raised ICP. We see the images. Mostly, most of these are in a traumatic patient where there will be a raised ICP on the CT scan. So most of them it is correlating.
So recently we have a patient came with ICH and patient is clinically stable. GCS is well preserved about 10 and CT scan is showing midline shift of 5 millimeters. We urged the surgeon to do something, but surgeon is telling it is okay to have a 5 mm of midline shift. So Chetan serially done all these things and he's urging the surgeon to better open prior to going into a bad situation. Surgeon waited for 1.5 days, then repeat CT scan showed it is more than 9 centimeters of 9 millimeters of shift. Then he realized that what Chetan said is correct and immediately taken to OT.
Are you doing serial things to do that? Persistently increasing the diameter
Chetan.
along with midline shift?
What's that?
No, because you take 1.5 day, you are doing repeatedly. Is it increasing?
Increasing trend.
It is an increasing trend, sir. Unless and until therapy, surgical intervention is done, then only we have seen some cases. After surgical intervention, we are having a decreasing trend.
Yeah, definitely it is useful in that condition to take the decision. Yeah.
Yeah.
Sir, in recent examination, these sessions also, there is a lot of focus on this, sir. They're saying that like mano e-fast ela chestamo, this also has to be sort of there is a lot of impetus on doing this. So I think we should sort of inculcate in practice, sir. I think only once we start doing it regularly, we'll know how to use it, sir.
I think in a trauma guide, this Win Focus guideline, they have included this as a regular practice.
Yeah, that's true. So they are stressing a lot on this.
Protocol.
Yeah, they are trying to sort of inculcate it. Yeah.
Madam was trying to tell something, Rani Madam. Hello? Rani Madam was trying to ask something.
David, TCD ki separate software kaval kada.
Yes, sir.
TCD.
Probe, same probe. I think it is different probe, but we are using that cardiac probe for TCD.
Oh no, but TCD separate
software
kaval kada, software.
Software kavali plus probe kuda TCD probe is different.
The TCD probe is very small compared to the cardiac probe.
Yeah, correct.
So ONST kuda ade kavala?
No, ANSG clearly they mentioned they had to use a high frequency probe with linear probe.
Rectangular probe, no, sir? Linear probe.
Linear array probe.
Yeah, linear probe is sufficient.
Basically a 10 megahertz.
Is 2D probe.
No,
sir. Linear probe is that vascular probe.
Vascular. Frequency should be higher, around more than 10, preferably to get a better resolution.
So not the curvilinear.
Vascular probe, linear probe. Now, is it okay? Can we stop?
Mohan sir.
Sir,
Cheppandi,
any discussion further or shall we close?
Sir, how frequently it is actually recommended to check the optic nerve sheath diameter, especially in borderline cases?
I don't think.
Ramanayadu speaking is a pulmonologist and FNB critical care, and he is having experience.
What type of cases, sir?
TBI.
And borderline GCS cases in traumatic. Generally, we will check hourly GCS in hourly pupils, neuro monitoring and all cases. But
basically, you have to understand the clinical scenario of that patient. If there is improvement, then you can measure every 4th hourly. And if you found that there is a deterioration, you can measure it every second hourly, preferably 1 hourly.
Okay.
What we are doing here, if there is any case comes like this.
You are doing 4th hourly, sir?
Yeah, 4th hourly. If a patient is on a traumatic brain injury, have received a treatment. So just see the trend, how it is coming. Usually optic nerve sheath diameter, if it is high, it will take at least 24 to 48 hours to come back to the normal position.
Okay.
Any this optic nerve sheath diameter related guided mannitol therapy? Means it is increasing mannitol.
There is no data as such, but only when what we were doing here, we were trying to measure optic nerve sheath diameter and invasive ICP. In that, we were trying to keep the ICP less than 20. We never anything we are trying to go about 20. We used to drain the CSF or we used to give osmotherapy. That's a mannitol.
If the diameter is increasing, can you give mannitol?
I didn't get so.
Suppose you said more than 5 is 20 ICP.
Yeah. Normally, they will give mannitol and it's possible try to drain some amount of the CSF.
Yeah, we can guide. This will guide the therapy of mannitol, no?
Yeah.
Sir, David sir, we need to correct it, sir. What is the problem? Here, as Satish sir has mentioned, there is a midline shift is there. So, which is increasing. So, we need to alert a surgeon to go for a surgery. Or if the patient is having some infarct, then we need to see, we are not using mannitol, we are using only 3%. But ultimately, you need to do imaging immediately if it is increasing. What is happening in the system? Why this ICP is there? So we need to correct that process, sir. Meanwhile, you can do this, give a 3% saline.
Yeah, mannitol, 3% saline, hyperventilation, diuretics, all these things to buy some time before alerting the surgeon to open the brain. That's all.
Rescue therapy.
Rescue therapy, yeah.
There are no more questions. We will conclude the session. Thank you, Chetan sir, for a nice presentation. I'm requesting to put the presentation in the group.
David sir.
Sir.
This ONS is normally mannitol. When we give, we should not give BD or TID. Every time we should check and give. That's what people says in the literature.
But they said it is not correlating, no? I asked the same question.
Okay, sir.
They said the diameter will not correlate with the mannitol. So, I don't know.
No.
Maybe neurosurgeon.
Then usually what Chetan told is, once diameter has gone up, coming back to normalcy, it will take 24 hours. It just won't come down immediately. So it may not give us a guidance to how long we should continue the anti-osmotic therapy.
If the size is increased, once I said 6 millimeters, by afternoon it is gone up to 7 or 8. Will it guide to give the mannitol?
Yeah, give the mannitol. Immediately take the patient to CT.
Yeah, at the
Identify it.
surgical intervention, CT and followed by surgical intervention.
Yeah. And the treatment won't stop just giving mannitol. Give mannitol.
No,
Take
it
the
won't
patient
stop.
to CT.
It won't stop, Anna. Just give mannitol and shift the patient for CT
Exactly.
and take the decision.
Yeah,
That's
true.
what
That is correct. Yeah, that's correct.
Yes, sir.
Okay, sir.
Right.
Thank you, Chetan. Thank you very much for a nice presentation. Thank you all for